Good morning. It was the anatomist James Hamilton in 1949, after studying 312 normal men and 104 eunuchs, observes the relationship between androgens, genetic predisposition, and age. In 1951, he published the article Pattern Loss of Hair in Men, Types and Incidence, and describes the standard classification of the male pattern. Norwood, in 1975, after studying 1,000 patients, published his article Male Pattern Baldness, Classification and Incidence, and he used the classification of Hamilton as a guide to develop and expand his own, with the variant type A. At the end of his article says, the possible variation of androgenetic alopecia are infinite. Designation of all minor types will not only be impossible but will reduce the usefulness of the classification. There are, however, several reasonable, well-defined variations that deserve special mention, as diffuse and pattern alopecia. In this type, there is a general decrease in the density of hair without any definite pattern, although it's usually more marked over the top and front. This type is common in women. Diffuse pattern alopecia. The patterns in this type of hair loss are essentially the same as in more common male pattern baldness, but the areas involved do not become totally bald. The hair only decreases in density. This also occurs in women. Male pattern baldness with persistent mid-frontal forelock, any pattern with forelock. Senile alopecia. This occurs in all scalps, male and female, with age. The role of androgens is uncertain. The decrease in density involves not just the top and side, but the entire scalp, but is again a diffuse alopecia. So that's important because, for example, can we define these patients as senile or advanced alopecia? They are young and has thinning in the donor, or this one. Is this an advanced and at the same time senile? This is what an advanced alopecia is: big recipient with short normal donor. Bernstein and Strassman wrote again about DUPA in 2002, when they were developing the follicular unit transplantation, and state that DUPA patient, men or women, is a relative contraindication for hair transplantation and FUE procedures, because a patient with DUPA will most likely yield temporary results that will be completely negated as the transplant hairs succumb to the androgenic condition. I've been working on FUE since 2003, and during my early years I didn't pay the proper attention to the donor zone. Only after some not good result, what some call the X factor, I performed several biopsies of the donor area that confirmed the existence of androgenetic alopecia. One of the patients was this one, 45 years old, diffuse pattern, no medication, very fine and small hair, very easy to transect, 2600 grafts, 2.1 hair per graft, and a non-bad result, but neither good. After 1 year, he began to lose recipient hair and worsen his donor area, so I did a biopsy that confirmed the androgenetic alopecia. So put the patient on medication and the donor improved slightly, and I successfully performed a new procedure to date. I started to look more closely at the donors, always with the USB microscope, focusing on miniaturization in the number of singles, and now with the dermalite and hair counter in the number of hairs per square centimeters and hair per unit, and I made my own guide to suspect androgenetic alopecia in the donor zone. Any patient, male or female, that has more than 15% of miniaturization in the donor site, and one more of the following: diffuse pattern in the upper part, mainly if they preserve the frontal hairline, less than 2.0 hair per follicular unit in temporal and parietal areas, less than 130 hairs per square centimeters in temporal parietal areas, more than 20% of singles, when we can see through in the temporal parietal areas. Different hair characteristic in temporal, nape and sideburn. I mean when the nape and sideburn has visible better coverage than the rest of the donor. Normal follicular unit with miniaturized follicular unit in the donor area. This is also weird. Not all the follicles seems to be affected the same, but can be part of the evolution. So I did my own protocol to do a procedure in those types of patients. They must understand that they have a non-stable donor area, must understand that medical treatment is a non-negotiated condition to undergo a procedure. Meds in the donor usually works and stabilize better than in the recipient. Must be almost 1 year under medication and must have a stable alopecia to do the surgical procedure. And the main treatment is finasteride, but dutasteride can be an option. And my reasons are: patients with or without DUPA that are happy with meds are very consequent and trustable. A stable hair loss with meds is almost the same than MPV patient in the long term. There are two different types of follicles in the donor in most of the cases, miniaturized and almost normal, that will be the target of our harvest. Why HT can be an option in women and not in men with DUPA, knowing that 90% of women have DUPA? Experience since 2010 doing DUPA patients showed me that they could have a good result in the short and long term. And there is also another term that I coined, hidden DUPA, defined as the patient that has thinning in the donor but looks like normal due to medication. And that's important to take in account due to the popularity of meds against hair loss. In Spain, we don't have much problem with finasteride, so a great percentage of our patients are in treatment the first time I see them at consultation. You will understand better with this opposite sample. This is a patient I saw in 2010 with an advanced and aggressive alopecia, 35 years old, Norwood 5 to 6, retrograde alopecia and thinning in the entire donor site, a typical aggressive male pattern baldness. Obviously, I told him that was impossible, and the only choice, but not so much convinced, was to try finasteride. When I saw him 6 months after, the donor improved and the external aspect was as a normal bald pattern. Obviously, with a microscope you still have signs of thinning, but if you don't pay attention, you can take him as a normal patient and do the procedure with a clearly and sure result in the short and long term. To summarize, we agreed to do his restoration, and after 3 procedures and 6,493 grafts, we obtained a very nice and young hairstyle, although still remain the see-through in his temporal parietal areas. So be careful with the hidden DUPA, and always take your time to double-check the donor. For example, this is a Spanish patient I saw that had a successful HT after 1 year, but lost most of his transplanted hair when he stopped taking finasteride. I put him again on meds, but never recovered his hair. If you see in the close view, he had thinning in his donor at the time of the HT. So, in 2013, Dr. Bisanga did a lecture in San Francisco, Miniaturization of the Donor Area, explaining that Norwood MPV patients can have thinning in the donor area, and he determined that 25 of miniaturization was the red flag to not consider that patient as candidate to surgery. I had a talk with him in Brazil 2 years ago, and he reminded me that Norwood never described the MPV with thinning in the donor area, and it's true. DUPA is a diffuse alopecia, thinning on the top, not bald. So, bringing again Norwood, he said, the possible variation of androgenetic alopecia are infinite. Designation of all minor types will reduce the usefulness. But at this point, I have to say that the amount of patients with MPV and thinning on the donor area are more frequent than we think, and it's not a minor type, so must be described as a well-defined variation and take it out from the back of the DUPA, where I have been including all patients with donor thinning. We must think that Hamilton and Norwood did not have the tools and microscope that we actually have, so it was impossible for them to evaluate the donor as we currently do. So I started to call it BUPA as bald and pattern alopecia to make a relation with the Norwood term and make it easy to remind. So currently, my description of both terms is as follows. DUPA, general decrease in the density of hair without any definite pattern in the overall scalp of a male or female patient that has more than 15% of miniaturization in the donor site and one or more of the following. Preservation of the frontal hairline, less than 2.0 hair per follicular unit in temporal parietal areas, less than 130 hairs per square centimeters in temporal parietal areas, more than 20% of singles. When we can see through in the temporal parietal areas, different hair characteristic in temporal, nape, and side pearl, normal and miniaturized follicular unit in the donor area in different percentage, and BUPA as any patient with a male pattern baldness as described by Norwood Hamilton that has more than 15% of miniaturization in the donor area and one or more of less than 2.0 hair per follicular unit in temporal parietal areas, less than 130 Hz per square centimeters in temporal parietal areas, more than 20% of singles, when we can see through in the temporal parietal areas, different hair characteristic in temporal nape and sideburns, normal and miniaturized follicular unit in the donor area in different percentage. This is a classification based on observation and experience, so it's open to discussion according to any procedure based on subjective judgments, and I will be pleased to hear your comments. Thank you very much.